example of a stepped wedge design. I'm just going to go over fairly briefly the general principles of these designs. And I have to confess, this was a learning experience for me because I've never actually done one myself, but I've tried to look at the literature and understand the main principles. So here we go. So this is the overview, and this will be a fairly brief presentation here, just with the main points. Some of the key features in the design, a couple of examples, how you do the analysis, how you should report them, which is useful. And then it was supposed to be Dr. Priscilla, who's one of the investigators on the big study. She is, as you heard, not actually here. And then we can have some discussion. And I have a few more questions about the brain injury study as well, just to sort of clarify how it's actually worked out in practice for that particular study. Note, my initials are actually SDW, and these trials are referred to as SWD. Nothing to, not the same thing. Okay? So if SDW slips in there occasionally, I might have meant SWD. Because I do SDW a lot, right? Okay. The best thing I can tell you for looking at this literature is this paper that I found, or we found actually, by Hemming and colleagues. This is in Open Access BMJ, and it's a really nice review, quite recent, and 2015, and and most of my slides are actually drawn from this paper, so that's the shortcut if you want to know more. So key features, they're often used, these designs, to look at policy or practice type interventions, delivery of healthcare at a cluster level. And the clusters can be things like wards within hospitals or whole hospitals, health districts, states, and we've seen this example just now where it was actually countries, whole countries can be the cluster. Usually, very desirably, there'll be an initial period when there's no intervention, and that becomes the control. So it's usual practice, whatever's going on now is the first time period. And then there's a crossover period, but just to be clear, it's not a crossover design. You don't cross over to something else and then back again as you might in a typical crossover trial. Everybody moves in the same direction in this step wedge design. You move from no intervention to intervention, but that happens at different times depending on the cluster. And so at the end, all the clusters should have been exposed to the intervention, and in the ideal setting, all the clusters are observed in both conditions, that's meaning with control or with the intervention. So you can classify these designs in a number of different ways. So the top left one, the parallel cluster study, is actually not really a step wedge design. That's where you have some people that have the intervention, or some clusters that have the intervention throughout the study period, and others who are the control who are not exposed to the intervention. So it's more like a parallel group study but with clusters as the unit of intervention. B is a slight modification of that, where some of the individuals who get the intervention, well, in fact all of the clusters that have the intervention also have this control period, but other clusters never get the intervention. And then C here, that really is a stepped wedge study, and the name obviously comes from the shape of this diagram, that clusters move over from control to the intervention at different points in time. And then the last one is a slight elaboration of that, where you need a little bit of time in between to actually transition over from control to the intervention. So we're mostly talking about these two, and I think the big study does have transition, right? Where's Jai gone? Disappeared. Sorry, I didn't see you there. So the big study is in fact an example like that, where there's a transition period. Right, so why would we want to do this thing at all? Somebody said it looks awfully complicated. Well, one reason is that for this kind of intervention with health policy or healthcare delivery interventions, they may be more acceptable than traditional trials because traditional controls in the standard randomized trial may not be recognized, or they may not be accepted by the public. So they may all want to immediately have the new treatment or the new policy. So that's why you might move in on a wedged basis where some people get the intervention earlier, but you still have the advantage of controls going on. Another major advantage, which I think is very common in this kind of study, is where you need a phase-in, and you may take some time to actually organize the changeover, and you may not be able to do it in every place all at exactly the same time. For example, you may need training, so you may need training teams to move around to those clusters to actually implement the intervention. And you can't do that for everybody at the same time. So those are two major reasons why you want to take this design. Some of the methodological issues, blinding may not be possible. In fact, I think it's almost always the case that you're not blinded because people know that something's going on, and you know that in this kind of study you are moving from control to intervention. So if something's going on, training or whatever, you inevitably know what phase of the study you're in. You should ideally recruit participants before the treatment allocation is known, and treatment allocation means here when you are going to change over, right? Because everybody does in the ideal study. And I think that's true for the brain study. So that hasn't happened yet? You haven't done the randomization? No, okay. So nobody knows yet who's going first and who will be last. Now another problem is that few clusters have the intervention early on compared to later. So you have this confounding. I raised that question before. So you have more studies that have moved over towards the end of the study. And so you've got confounding with any temporal trend. So if there's, say, an increase in the incidence of the disease or the severity or even referral patterns to these hospitals, if something's changing over time, you have a problem with the analysis because it'll be confounded with the intervention. As Jai mentioned briefly, because we've got clusters, we have to allow for that in the sample size calculation. And as we talked yesterday, with clustering, with large cluster sizes, even a small intra-class correlation can be very important. It can really inflate the required sample size quite a lot. So it depends actually whether your cluster effect is weak or strong. So if you have a low intra-class correlation coefficient, you may actually be better off to use parallel group studies. But if the cluster effect is strong, you're better off to use this idea of crossing over with these step wedge design. So it depends on exactly what the parameters are as to which is the best approach. The analysis should look at temporal effects because of this possibility that things are changing gradually over time, and you do have confounding with the intervention. So you do need to worry about that. And as I think you mentioned for the brain study, you do have before and after paired data within clusters. And if you have enough power, and you do, in the brain study, you can look within each cluster. And that would be important, particularly in an international study like this, where healthcare delivery and even the disease could be different by country. And so you actually want to have a reasonably good answer for each one separately. Am I correct in that? Yeah, okay. So here's an early example that you'll see in the paper. I'm sorry if this is a little bit small in your printout, and I think I have yes, that's right. So this is to look at a vaccine for Hep B, so preventing liver disease. And the key elements of the design here, I'll just read it because it's small. Geographically designed areas of the country, this is in the Gambia, were randomly allocated to incorporate the vaccination into the existing vaccination schedule for children. A new region was randomly allocated in steps of 10 to 12 week intervals, so that eventually complete national coverage was obtained after about 4 years. So they couldn't apparently do that for the whole country on the same day or even in the same same year, they had to phase it in, and that's why they used this design. So that was a very early one back in the 1980s. In choosing this design, you've got quite a lot of choices to make. When are you going to observe people? And is it going to be the same people at different times? Are you going to be following them cross-sectionally and then moving forward in time? Or is it going to be different people at different times? So is it an actual cohort that you're following, or is it going to be repeated cross-sections with different people coming in? So if you have nursing homes, for example, for senior homes residents, you might have different people present at different points in time. Another possibility is a hybrid where you have an open cohort where people come in and out of the cohort. The number of clusters, obviously an important design consideration, number of observations per cluster, how many steps do you want to make, and how long should all of the steps be? So several examples now just of these different designs. Parallel groups with a baseline period. So this was actually an economic study financing healthcare, and says it was evaluated by phased and random implementation. That's what they called it. And here's the key element of the design. 74 clusters. There's a lot of clusters. That's good, of course. Were matched in pairs so that one received the intervention and the other acted as control. I don't remember offhand what the matching was on, but it was presumably to make the areas where they had the interventions comparable. So they might be, for example, urban, rural, or certain demographics that you would try and pair up so that they're comparable as you introduce the intervention. Yes? Question?
Evaluation of the Mexican Universal Health Insurance.
Yes.
I just wanted to know that what intervention they gave.
You want details of the actual intervention?
Yeah, because
is that your question?
Because they are just doing the evaluation. So intervention, what intervention they might have given?
I don't know. You'd have to look at the details of that. If you want to know what the actual intervention was, you have to go to the original paper. I'm sorry, I don't know those details. Yeah.
Does it qualify as a step design?
Well, no, it isn't. It's not. It's one of those other ones that, strictly speaking, isn't a step wedge design. But you do have a baseline period and then a crossover to the intervention, and it was done with this design with the paired intervention. Some got it, and some didn't. So it's a before and after. I mean, you could include it as a very simple case of a step wedge design, but there's no steps and no wedges.
So one thing, the basic question to design, the steps we are talking about, these steps or these steps?
Yeah.
Because if you are able to do the intervention in all clusters at one point of time, suppose I have resources, I have training teams ready at all the clusters, and they're able to do the intervention, deliver the intervention at the same point of time, so we'll not have these steps, but we still have these steps in terms of control period, intervention period, and the post-intervention system.
That's right. They all have, the first one, the parallel group design, does not have before and after, but all the others do. Right? You always have before and after, and it depends.
No, I'm saying before and after, but intervention in the same time, not on the different times.
Yeah, it could be. Well, okay, I need to go back.
Just that design aspect.
I'll just go back here, sorry.
On that 4 quarter, one.
This one.
If this is at the same time.
Well, yes, that's right.
Third
The ones that got the intervention, it all happened at the same time, but not all of them did.
No, if this is across the board, everyone got the intervention at the same time. See that on the...
Yeah, well then there would be no wedges, no steps. It would just be a before and after study for everybody. Okay. The problem with that would be that you'd have complete confounding with time, right? So if you're comparing healthcare financing, in the 2010s versus an earlier time period, there are other things that could be different, and that would be totally confounded with your intervention. Whereas at least in this one, you have the possibility to allow for that because you have some people who continue on the control.
Yeah. Okay.
Right? So this, I guess you could say there is one step there. It's a very simple case. You missed what the advantages were. You perhaps weren't looking at this slide when I put up step wedge design that says advantages. These are the main advantages. People.
Technically also this is more correct because later nobody can question that they have not received the ideal or the
No, but treatment.
Okay.
This advantage also stands true for pre-post trial. See, typically pre-post you also giving intervention to everyone.
That's true, but if it's just a pre-post, you have the problem of confounding in time, so it's not a solid result. I think.
So that's a cluster level analysis you're talking about, where you do this confounding effect.
We haven't come to the analysis yet. Can I come?
I'm just saying.
Yes, we haven't actually.
Interest in the cluster level, a different level, what's happening in the cluster level.
Okay, there's a lot of things going on here. You may be interested in the results at particular clusters, as in the brain study. You want to have a result for each country because they may be potentially different. That's a reasonable question to ask. But I think my sense is that the main advantage for using this design is logistics, because you can't make an intervention on everybody at the same time. And you can only, you've got training that needs to go on. You have to have a training team that goes around to different hospitals or healthcare centers and trains that cluster. Now next month we'll go to the next cluster and so on. So it's for that kind of reason that you more or less have to use this approach. Yeah, and also you obviously can't go back, not very easily. You have to. You're kind of committed to making that intervention and staying with it. Yeah. Did you want to say something, Joy? Do you have a comment?
Let us try to understand the first point of it. The figure 1 says yesterday we talked about cluster designs, randomized cluster. I randomized 5 clusters to get the intervention. 5 do not get the intervention. So I compare it. But the disadvantage is that 5 clusters did not get the intervention. But in a step-wedge design, everybody gets the intervention. That is one reason. Why step-wedge? That process said there is a time period to prepare and put the intervention to each cluster. Above all, there is a time component. Brain infection study is supposing I hypothesize that infections are time-related thing. Then temporality is there. Therefore, I phase it out at various levels, and it is country-specific. So therefore, it will allow me to look at the temporality of the infections in India, Brazil, Hawaii or whatever. So these are all the other advantages. That is why we are phasing it out like this. So it allows you to do that one. In a way that is, I see as the main.
Yeah, I mean, this particular study is brain infections. So if it's infections, you do have to worry about the possibility that there might be changes over time in the disease event rate, the incidence of the disease. And that would constitute confounding with your intervention as a result. Yeah.
Related to the geographical scenario, cluster migrate the different countries. We really want to see what is the epidemiological thing happening to the infection, the different countries, different populations.
Yes, that's right. In this particular case, because it's countries which are obviously very different, the clusters are, well, I don't know, Bangalore versus Vellore, maybe that's more similar, but the other 2 clusters are very different because they're in different countries. And it's very reasonable to ask the question, what's happening in India versus the other countries quite separately. So that's absolutely fine. It's like you've got a set of separate studies, but if you only did a before-after study in each cluster, you have the limitation of what you can say with a before-after study with total confounding with time. So it's in the step wedge design, at least in this example, what you're effectively doing is putting 4 separate studies together with a carefully controlled approach so that people get it at different times, get the intervention at different times, at least allowing you to disentangle those things, the time effect and the intervention. So it's it's almost like a hybrid of a pooled analysis of 4 separate studies versus one integrated study. Yeah.
that post-intervention, the follow-up period is not the same in all the.
Yes. Yeah, that was, we can come, but we can. what I'd suggest is we can come back to specific questions about the brain study in a moment, because you pointed out that we have different time periods and different amounts of follow-up, which could be an issue for the brain infection study. So that's a good point. And I was trying to get at that with one of my questions as well. Okay, let's just try and go through these examples. There aren't too many more of these. So we talked about this one. This was the healthcare financing study in Mexico with a lot of clusters. The next one is it's a cohort study. This is based on nursing homes or seniors' homes. And as it says there, homes are randomly assigned to one of 5 dates to introduce an intervention to promote a diagnosis and management of depression. It can be pretty depressing in seniors' homes. So there you go. So you have 17 homes. That would be the clusters, right? The cluster would be a home. But we have 5 different intervention periods. So, I don't know, 2 or 3 in each time period when you switch over in the procedure to diagnose and manage depression. Okay? It actually says there, 3 or 4 homes randomized approximately every 4 months. So again, that might be mainly chosen, that design, because of logistics, that you'd have to have training teams that would go into these seniors' homes, nursing homes, and train them on what the new policy should be. And so you move around every 4 months and do a new group of homes. Okay? And this is what's called an open cohort, because these are seniors, they may not be around for the full period of follow-up. So as you do the assessment, within each of the homes, you may actually have different people present. So it's an open cohort rather than a closed cohort where people stay the same. In this one, let's see, just remind myself, this was to do with improving care of patients undergoing emergency laparotomy, complex intervention, so they're looking at the procedures to take care of those people. An intervention would be rolled out sequentially to 90 hospitals. So hospital obviously is going to be a cluster, but there are 6 clusters of 15 geographically close hospitals. That's clusters within clusters, right? So we've got 2 levels of clustering. One would be the geographic areas, and there are 15 of those. And then within each of those, 6 geographic areas, that's the first level of clustering, and then within each of those you have 15 hospitals. And clearly you have differences between hospitals but within areas, so it's a second level of clustering. So they switch over from control to intervention every 5 weeks at 15 different time points. Okay? So there's a 5-week transition period. We talked about that in the brain intervention. This is to get people used to things, going from the old method to the new method, and you have a variety of staff people that you'd have to familiarize with the intervention and so on. The outcome, 90-day mortality and so on. There are other details there. Okay, so that's a diagram for that particular study. This is a fairly elaborate one. There's the little white box in the middle with the transition period for each of the clusters, and the total goes all the way down there to 90, so they have 90 hospitals that eventually would be transitioned to the new intervention. But notice then that at the end we have a lot more hospitals that are on the intervention than there were at the beginning. So again, that problem of confounding with time. This is something again from that BMJ article, just pointing out this question that the design that you choose might be dependent on the intra-class correlation, the intra-cluster correlation in this case. These, I think, are all designs with 20 clusters, 50 observations within each, so they're all comparable, having 1,000 people in total. And they've got here different designs with no steps. That would be the simple parallel group design. One step, that's where you have some units with a baseline period but others not, and then the full stepped wedge design. And of course what you want is optimal power to find the effect. And it turns out when the intra-cluster correlation is very small, only 1%, your best option is actually the simple trial, the simple parallel group trial. But if it's a larger correlation of 0.1, not 0.01, but 0.1, then the step wedge design gives you much greater power than the parallel group design. And of course that's independent of concerns about confounding with time. That's a separate consideration. And as Jai pointed out, getting data on these values for the inter-class correlation is quite difficult. Quite often difficult to know how much of an issue that's going to be. For the analysis, there's various things that you can do. It's either a linear model or a logistic model, depending on your type of outcome. You do have to allow for the clustering effect, for sure, and you also have to allow for steps. That's effectively allowing for time when the changes took place. If you have cohort data, you're going to have repeated measures on the cohort with random effects for the individuals, allowing for variation between people. We can do within cluster estimates, as they're going to do in the brain study. So that's just basically a before-after comparison within the clusters, but that cannot take account of temporal trends. It's totally confounded with the intervention. And you may want to look at the heterogeneity of the effect of the treatment over time. One of the things I noticed, by the way, we haven't talked about this before, but in the brain protocol, I noticed it said something like the intervention that takes place in the later clusters would be informed by what happens in the earlier clusters. So the actual intervention itself might change over time during this study, which is an interesting point, which could be good or bad. And heterogeneity between clusters. So we've got that one covered in the brain study because you've got good power within each of the countries. So you can actually look at the main effects and probably have a decent look at heterogeneity as well. There's some guidelines for reporting these studies. You know about Consort. Maybe you don't know about Consort. Consort's a set of guidelines for how to actually publish and report on clinical trials in general. And there have been a number of extensions to those guidelines for specific types of study. And this is the one that came out in 2010 for clusters. And the modifications are as proposed by this group headed by Henning. So here's a report, for example, about the number of people that you have in the different time periods of the study, various clusters, and you've got the number of new recruits in each cluster and the time period, and whether it's interventional control. So you can see how many are exposed or not exposed. This is a little checklist of the kinds of things that you need to look at this in the original source. These are the special things that apply to this particular type of study. So, for example, it includes the definition of the cluster and the cluster size, the length of the steps, observation periods, how many are randomized at each step, and so on. Rather than just saying, oh, we did a study and here's the aggregated data, we need to know all these detailed features in order to interpret. Sample size, justification, allowance for clustering, the number of steps, and so on, repeated measures, all of the key features affecting the variation. I won't say any more about that, but some of them make obvious sense. And this is actually an area of ongoing research. So how do we design properly studies that have clusters within clusters? So that could be wards within hospitals, but we saw the other example of hospitals within geographic areas, so there'd be clusters within clusters. What happens if we have trials with more than 2 arms? Well, we know what to do, for example, in dose-finding studies, in pharmacologic trials, normal trials. Much less is known about it for this kind of design. What about the effects of restricted randomization with pairing, as we saw in that was the healthcare financing one, I think. And what do we do about if cluster sizes vary or we have different step sizes? All of these things need a bit more work. So that's a very active area of research.